Hello, my name is Jim Kohner. I'm a periodontist, as you can see on the slide, and have been teaching hands-on surgical workshops for the PERIO Institute for 12 years now. The company has been in business for over 30 years and is based in Snoqualmie, Washington. The waterfall in this slide is just down the street from their office. I teach both crown lengthening and soft tissue grafting workshops, but they also offer hands-on workshops on the subject of PERIO surgery, bone grafting, oral surgery, as well as an implant training course. Check out their website at PERIO.com, which will be listed on the final slide that you see today as well. So I have some objectives for today's webinar. Let's go through those first. First of all, I would like you to see ways that soft tissue grafting can help preserve the bone and soft tissue around implants and make them more easily maintainable. Also, as you see here with Marilyn's Frenum, we can manage the Frenum areas quite nicely, both around teeth and implants, by the way. And one of my favorite uses of soft tissue grafting is the prevention of recession around teeth in the aesthetic zone where there's just been recent crowns placed. Sometimes people report within the first 6 to 12 months that their patients have recession. I've had over half the people in the workshops raise their hands when I ask that question. How many of you see this? Recession around a recently placed crown in the aesthetic zone. Soft tissue grafting, one of the best uses of it is to prevent that recession by identifying that thin tissue you see on the left photograph in Joanne's mouth. Also, another great use of soft tissue grafting is to stop recession once it's started. This application can be used in both teeth and implants equally, and you can see that in Norma's situation where she's got these two teeth. Here's one that have recession. We can stop it in its tracks. And another wonderful use of soft tissue grafting is root coverage for aesthetic purposes, as you can see here in Robin's illustration, or it's the same application of root coverage in the case of sensitivity problems. Now that application, getting root coverage with soft tissue grafting, is only applicable around teeth. Implants will not have that same result because there's no periodontal ligament. So I have other objectives for the workshop, the webinar today. One of them is that you'll be better able to answer that question, to graft or not to graft. And then by the end of this webinar, maybe have a sense when you see situations like Norma here with the 2 areas of recession, Stacy with recession around a labially placed root with extremely thin bone, and Meredith with some aesthetic situations that she would like improved. So hopefully this webinar will give you a means for answering that question and understanding how to manage these different clinical situations. More goals. Better restorative results. That's what this really is all about. All of these applications of soft tissue grafting are designed to enhance your restorative and your aesthetic results, implant restorative as well. And that you should have the peace of mind when you do place that crown in the aesthetic zone, that you know with absolute certainty that the tissue will stay there and you won't have that dreaded phone call in 6 or 8 or 12 months. Why do I see the root around the crown you just placed? Predictably, better restorative results, better peace of mind. Now, there are all kinds of soft tissue grafting procedures that have been in the literature, that have been used clinically for many decades. They go from the more simple apically repositioned flap over here on the left, coronally repositioned flaps, laterally positioned flaps, as well as free gingival grafts and connective tissue grafts. Laterally positioned flaps, for instance, have some problems, as do apically repositioned and coronally repositioned. But one that I wanted to show you is the double laterally positioned flap. Look at this difficult suturing. Yes, I did this one. No, I would not want to do it again. Very technically demanding. So instead, we're going to focus on just two types of grafts that are extremely useful. Gingival grafts is one. Yes, I maintain that it's essentially 100% predictable if done correctly and if the cases are selected correctly. Wonderful in the mandibular anterior where aesthetics is not a concern because we're not getting root coverage. That's not the goal. The goal with gingival grafts is to stop the recession. And you can see here how it's done for Stacy in the mandibular anterior. Do free gingival grafts last a long time? Absolutely. Here's an illustration from a recently published article in the PERIO journal by colleagues in Italy. The PERIO group works pretty exclusively in the soft tissue arena. And what I'm showing you here, with their permission, is one of the cases from their study, a 23-year gingival graft result. Stability in gingival grafting does exist. And in my own hands, Norma, who we looked at just a little bit ago, you can see that we did not make an effort for root coverage. So initially, we have created a zone of gingiva that will stop this recession that you see here. But look at the benefit. After 14 years, she's even had some creeping reattachment. Now, you can't count on that. If you want root coverage, you would be selecting a different procedure. But what I'm showing you is longevity, free gingival grafts do work. And the other procedure we're going to focus on is a subepithelial connective tissue graft, conveniently called connective tissue graft. It's subepithelial because we lift up a trap door on the palate, and we take out from underneath the trap door the connective tissue to use as the grafting material. Also extremely predictable, wonderful in the maxillary aesthetic zone, wonderful in that application. And again, reading the literature, the PERIO group contributing to it as well, that this procedure is more difficult to do in the mandibular anterior because of the muscle pull. But we have gingival grafting to use there, and we don't have to be concerned unless there's a sensitivity issue or the patient really wants root coverage. Now, I said difficult in the mandibular anterior. I did not say impossible. It can be done, as this case illustrates, but it does take much more time and skill to get those same results in the mandibular anterior. So let's compare the two grafts. Gingival grafts, excellent, as it says here, for stopping recession. And you see how the graft is done, laid on top of a prepared recipient bed. And you can see the results. Connective tissue grafts, they're good for root coverage, but notice that the graft here is inside this envelope flap. So you don't see the graft. It appears to be that double blood supply of the flap over the graft and the periosteum under it that gives this tissue a chance to stay viable and stay alive over the avascular root surface. So we're talking about objectives and what I want you to understand today. Let's go back to the 5 things I said at the beginning as far as what our goals are. Preserving tissue around implants. All right, so now we go back to the early work of the Brandemark group. And in their first textbook published in 1985, this is a quote, "Keratinized tissue is not necessary, but preferable." That's what they said. And you know what their contribution has done to change our field and the world has been remarkable. And in this one small area, I think that we've learned something different since they made this original statement. Just recently in the PERIO Academy AAP journal, JPERIO, there was a published study. 11 studies were reviewed, and they concluded, colleagues at Ann Arbor, Michigan and Taipei, that the lack of keratinized tissue leads to more plaque and inflammation around implants. So we have a different understanding now than we did when this was first introduced to us by the Brandemark group. So let's see how using soft tissue grafting can change the environment around implants. Bob is a young man, lost a bunch of teeth and a large amount of bone in an auto accident. After a wonderful grafting procedure, bone grafting procedure, by an oral surgeon here in town, there was a mucosal border around all the implants because of the way he had to advance the tissue. Bob was referred to me where we placed a large gingival graft, and you can see the results several months later. A good zone of tissue to accomplish what we want to as far as eliminating the tendency towards inflammation and facilitating plaque control around the implants, both essential ingredients. So after implant placement, we can still modify the tissue around implants. Also, after implant placement, we can manage a different case. Notice Nancy had a large amount of bone lost along with her failed teeth. We can see here that if implants were placed, they would be bordering mucosa. So let's see how we handle that. Bone grafting is done to build out the ridge. Then implants are placed, again, like Bob, knowing that it's okay to have mucosal margins because they can, of course, be converted later on after implant placement. So here you see the mucosal border, and here you see the nice keratinized tissue done following a gingival graft that was done after the implant placement. I also have another technique that I would recommend that I am very fond of myself. Before implant placement, we can also use gingival grafts. So you might have a situation like Joe, who's been without teeth for some time. He's lost keratinized tissue, but there's enough bone there that he can still have implants placed. But we can see easily that the implants would be into mucosa. So what I'm recommending that you can do is a gingival graft is done with an incision right here into the keratinized tissue, all the way back as far as you need to go. And a gingival graft then is placed adjacent, abutting to the keratinized tissue. When that heals, can you now picture the nice zone of gingiva that you'll have so that the implants can be easily dropped right into the area with a punch procedure or a flap if you prefer it. So gingival grafting post-implant you saw with Bob and Nancy, pre-implant placement with Joe. Soft tissue grafting around implants can be very useful. What about the frenum? We saw briefly Marilyn's situation before, but we also have an implant situation to show you how we can manage the frenum around implants as well as teeth. I did not place Avery's implants. So when he was referred to me, his chief complaint was, the area is sore whenever I brush it. After some consideration, he and I and his dentist concluded it was more than likely the presence of this frenum coming high up on the tissue that was causing the difficulty. So gingival grafting is done. No expectation of root coverage. Again, it's an implant, no periodontal ligament. Just trying to create a zone of keratinized tissue to control the loose tissue and the frenum and facilitate his brushing. And you can see the final result. What's interesting about Avery's case that has stayed with me all these years is that I clearly remember him saying within that first week, while he still had sutures in place, he could do some gentle brushing, and it felt better than it did before the surgery. So despite being 1 week post-op, sutures still in place, he said the brushing was already better. So frenum management in the implant arena. Teeth, same opportunity. Marilyn also is complaining about soreness in brushing, just as Avery was. That kind of helps as a red flag to guide us to knowing that the frenum might be involved. And you can see the large extent of the frenum here. And in the direct facial view, you can see the lack of keratinized tissue, recent recession that she says only the past year or a little longer than that. How can we get rid of the soreness? That's her concern. So you can see the pre-op, and you can see the 6-month and the 3-year post-op. What's also interesting about this that you will not see in an implant case like Avery is that we did get some creeping reattachment, just like in Norma's example, as the tissue heals over the years. Creeping reattachment, only with teeth, not with implants. So that brings us to what I said before is one of my favorite applications of soft tissue grafting, the concept of identifying thin tissue prior to doing restorations in the aesthetic zone. So that in Joanne's situation here, you can see the probe shining through this thin tissue. Now she's in temporaries. All these are temporaries. It's a big restorative case. Here's the thin tissue. The graft is done with the goal of creating marginal stability. We want healthy, stable, new marginal tissue. I say this is a recession area waiting to happen whether Joanne is restored or not restored. And this is what I want you to identify. When the tissue is that thin that you can actually see the probe. And now you're going to insult the area with temporaries, impressions, diamond burrs underneath the tissue. All these things are going to easily create recession, so that sometimes restorative dentists have told me when the case comes back from the lab, recession has occurred from the time of the impression to the time of placement. We can prevent that with this concept of getting good marginal stability. And what we can do then is know with confidence in the peace of mind that I referred to earlier that you can place this crown margin to the zone of gingiva and it will stay there. Now I like this concept of marginal stability better than a submarginal gingival graft. I did not place these. I don't know how stable this marginal tissue is. I just don't know. I'm sure this gingival graft helps slow down any potential recession. But if I wanted to count on that marginal tissue to be stable like it is here in Joanne's situation, I would not be putting a submarginal gingival graft there. That would not be predictable. So the message here is look for these areas of thin tissue when you're doing a large restorative case. I would really like to know that you can prevent that from happening the next time around. The fourth objective that I mentioned earlier was stopping recession. Norma is a classic indication. She has recession around 2 teeth. We're going to go ahead and graft the whole area because it would be close to impossible to just graft the 2 teeth individually. So the middle one, it gets grafted just because, sort of like extension for prevention, we have to make the graft bigger than the actual site. So we're going to connect these two with one big graft, stopping the recession in its tracks, predictably, every time, if you make your graft big enough. So that's why I make it wider left to right and plenty big top to bottom to be sure that we avoid any potential shrinkage. Here's another excellent example of stopping recession in a situation where Colin is missing his second bicuspid and his second molar. So he's beginning to have bone loss around his first molar abutment and recession. We explained to Colin that it isn't just a little gum recession, but also some bone loss that's allowing this gum to deteriorate, and that if we do a gingival graft, we can stop the recession and, very important, make a note, explain to patients we're also going to stop their bone loss. I think they relate better to bone loss concepts than, quote, a little gum recession. So there's Colin before we did anything. You can see the recession, and you can see that there is still some keratinized tissue. But notice this is not attached gingiva. Yes, it's keratinized, and we tend to call keratinized gingiva attached gingiva, but in fact, this is unattached keratinized tissue. It's fair to say there is no attached keratinized tissue in his case. A gingival graft predictably creates a zone a fibrous barrier that will stop the recession, help control inflammation, and protect the thin underlying bone. Some people might argue that you could do connective tissue grafts here, and I would agree, you could, but my question is, why? It's not a sensitivity issue. Colin's happy to just know that he can have the benefit of stopping recession and stopping bone loss. So a gingival graft, which is less technically demanding than a connective tissue graft, is my treatment of choice. And Stacy, we looked at her briefly before. There's a bit of a story here. Stacy's dentist said to her that she had some gum recession and suggested a periodontal referral. And she responded, "Why would I be concerned about just a little gum recession?" Well, to his credit, her dentist did convince her to come anyway for a consultation. And she did. And I explained to her that there is a tendency when teeth erupt to the labial that the bone is very thin, and as a result of the thin bone, they tend to have less keratinized tissue, and recession is not unexpected. So what's our goal? Our goal is to thicken the tissue with that fiber barrier that you saw earlier and protect the thin bone from any ongoing inflammatory insult. Once Stacy heard that we're trying to protect the bone, and she could see how thin the tissue was over the cuspid root, now she was more receptive. Yes, let's do it. Now I'm interested, she said. Whereas the concept of a little gum recession didn't motivate her that much. So here's what we have, a 2-year result, fiber barrier, stable, protect the thin underlying bone. And in Melinda's case, we can also protect thin underlying bone on teeth that are not labially placed. So her situation is similar without the labial displacement. And look at what our goal is. I want fresh marginal tissue here, as we saw earlier with Joanne, fresh marginal tissue for marginal stability. I want to know that I stop the recession, and I want to know I protect the underlying thin bone. The adjacent two teeth, the blue arrows, they can be submarginal because they don't have recession. We're only going into those adjacent teeth to have a graft big enough from left to right that if it shrinks some, as they tend to do, the literature says they could shrink 25%. I mean, and sometimes they do. But if you've made a graft that's quite a bit larger than you need, you can handle some shrinkage, and there'll be no ill effects. So here you see the pre-op, 3 weeks with the tissue reforming, and an 8-year stable result. It does appear, doesn't it, as if the graft might have shrunk a little bit. But no problem. We've made it big enough, stable enough that we've protected the thin underlying bone, and maybe there's a little creeping reattachment here as well. We do get that. If we want a complete root coverage, we would be doing a different procedure. Now, while we're talking about gingival grafts, some of you are probably thinking, oh, my patients don't like gingival grafts. They complain to me. They've heard it's painful. I've heard that as well. And you know, frankly, I've also injured some people's palates and made them quite uncomfortable. However, I have a technique that will absolutely control discomfort on the palate, control bleeding on the palate, make it easier for them to eat and sleep and talk and work. That is to use a vacuform machine to make a thin plastic suck down. You can see here how it's trimmed to be onto the teeth, not extending onto the soft tissue, because if you did a graft up here, the plastic on the soft tissue would cause problems and dislodge the graft. Place it in the mouth after trimming it onto the teeth, and also like you would trim a denture, you see, off of the soft palate. Put it in the mouth after the procedure with some foam. That would be the thicker of the foam type of products. I mean, of the collagen type of products. The tape products are too thin. The foam is squishy and takes up some room underneath the gizmo here. People are comfortable, no bleeding, no pain, able to eat quite comfortably. So if you've got patients concerned about doing gingival grafts, you can assure them that this will work. And if you're working with a periodontist and they're not using this, I think it would be worthwhile you suggesting it to them, because I can assure you it has made a huge difference in the comfort level of everybody that I've used this on. So those are my thoughts on gingival grafts. Let's look at another application for soft tissue grafting, and that would be the idea of root coverage on teeth, not implants, for either aesthetic applications, as you see here with Robin, or sensitivity issues. Connective tissue grafts do allow us to accomplish root coverage, as you can see here, in multiple different applications, whether it be one or more teeth, previously restored tooth surfaces. I'll show you a case like that. Sensitivity I mentioned, caries, or maybe you placed a crown and it did recede, and now you're embarrassed by that. Well, you don't have to redo the crown. Root coverage can, if it's an early situation, an early case, you can get root coverage over exposed roots and exposed crown margins. Plus, connective tissue grafting can simplify your restorative challenges. In Joanne's case, you can see the long custard roots. By covering that up partway, we can make a much more aesthetic restorative result. And it's easier to deal with than those long, difficult to prepare custard teeth. In addition, root coverage with connective tissue grafting will enhance your restorative results. That was one of the things I said right at the beginning of the webinar, is that we want better restorative results. So another Joanne, Joanne S., has exposed root, and she's ready to replace this gold restoration with something more aesthetic. So do you want to just do the restoration, or do you want to enhance your restorative results a little more? You can do that with connective tissue grafting, because we can get root coverage and have a properly proportionately shaped tooth. And once again, 8-year result, stable result. But don't get too excited, because there are limitations. Be careful. You go back to your office the day after watching this webinar and you see recession, like with Melinda. This is the same Melinda that we looked at with the mandibular incisors. And you say, oh, Melinda, we can get root coverage here. Well, be careful, because this is not so much root coverage as coronal part of the tooth coverage, and you're not going to get that. What's occurred here is that there's been enamel erosion on her tooth. You cannot get root coverage up above where the original anatomical CEJ was. That's dictated not just by the CEJ, but by the bone in the periodontal ligament. So we did not even make an effort to do root coverage here. No, instead, we did a gingival graft. Once it was fully healed, 4 or 5 months, then we could go in and do a restoration. But don't get excited when you see these erosion situations and think, oh, great, I just learned about root coverage. Would you like to do that? No, this is a limitation. Be aware of these erosions and missing CEJs. So let's look at some opportunities with connective tissue grafts. Here's an example of what I was talking to before, of a crown placed in the aesthetic zone with recession that occurred within the first 12 months. Now, yes, this is a first molar, but Janet has had 4 bicuspid extraction to have ortho. So her first molar is in the aesthetic zone. And frankly, as you might guess, she's annoyed that within 12 months, I think it was close to 12 months, that she now sees the crown margin and the root. She's not happy about it. But fortunately, as I said earlier, it was recent enough, minimal enough, that we could go in there now and do the root coverage procedure to get back the aesthetic result that she wanted. So this is the first molar at 11 years. Here it is at 5 years. I think it actually looks better at 11 years, don't you? The tissue's matured nicely, stayed stable, the crown margin is still protected. She's delighted. Yes, predictability. You can make people very happy with these kinds of predictable results. Noreen has a sensitivity issue. Just this one tooth, post-ortho, is her concern. Can we do something about it rather than a big Class 5 restoration? Sure, absolutely. Good bone, good soft tissue interproximally gives us the kind of predictability that we need to get root coverage. Without that, we would not have the same result. If we were missing bone and soft tissue, we would not be able to get nearly 100% root coverage. The way it's achieved here is that envelope flap that you saw earlier in the graft. It dropped into the envelope flap, which is then closed over the graft. And, like I said, predictable results that we could eliminate the exposure and thus eliminate her sensitivity. We saw Robin briefly before as well. In her case, it's not sensitivity, but it's the exact same procedure. Good predictability can be expected here because, like Noreen, she has good soft tissue and good bone interproximally. You can see it well in this photo as well. The envelope flap is raised, splitting it, which is a bit challenging because we don't use verticals. We do not use verticals. They heal slower, they're painful, they're hard to suture. We can extend horizontally if we need to, but no verticals. So splitting the envelope flap to leave, this is the double blood supply that I talked about earlier regarding the success of connective tissue grafts. Here's the periosteal blood supply, plus the overlying envelope flap will provide its blood supply. So the connective tissue taken from within the palate can be placed into the envelope. The envelope then advanced over it will yield results like you can see here. 6-year result, here's the pre-op, 6-year result, and 10-year result. Good predictability for root coverage procedures when we have adequate amounts of interproximal soft tissue and bone, which is referred to, by the way, as a Miller Class 1 or Class 2 after Preston Miller, the periodontist who helped us understand these classifications. Another application that I mentioned to you earlier for root coverage was on teeth that had been previously restored. So Hillary now is ready to enhance her smile. We take out the Class 5 restorations. And you can see here the root, after all the restoration has been removed, is now just treated as a regular tooth. Yes, we'll take a very smooth diamond burr and eliminate any sharp edges or drop-offs, any sudden drop-offs into this concavity. And then we're going to treat it just like a regular exposed root. Notice also the loss of enamel here, as we saw with Melinda. These CEJs are straight. You know CEJs should be more curved. See how straight it is? There's been loss of enamel. So therefore, she is alerted to the fact that she will not get complete root coverage. There's a special, wonderful little surgical device that holds 2 scalpel blades. Randy Harris is a periodontist who helped to create that. So you can see the double blade takes a very nice, even incision and a nice, even graft from within the palate. Here's the graft, nice, even thickness. Don't have any real thick or thin or void spots in it. Inside the envelope once again. So I don't know if you noticed or wondered about the fact that we leave some of that graft exposed. That is okay. You can see that when it heals, it completely heals as we anticipated. Of course, leaving some of the root exposed because that's lost enamel. So she knew in advance, Hillary knew in advance, that there would be some restorations. Now, as far as leaving the collar of the tissue exposed, there are two considerations here. Number one, what about this epithelium that is at the top of the graft that comes from the palatal tissue when you use the double-bladed handle, like railroad ties, making two lines on the palate? The epithelium between the two lines is part of the graft. Should we cut it off, as we did with Hillary, or leave it there, as we did for Robin? Well, actually, many of us did not know which was better, and we did it both ways and found the results were good both ways. So why take off the collar? Well, we weren't sure, so we sometimes did and sometimes didn't. And then about 5 years ago, 2009 or so, colleagues at the University of Michigan published a study where they found no difference in healing between leaving the collar on or taking it off, which validated our previous observations. And we went ahead after that and started leaving the collars in place. Now, what about leaving some of the tissue exposed, as I mentioned with Hillary? Well, there's been another publication just recently in a digital journal of the AAP, the PERIO Academy, that leaving the graft exposed is better. Actually, what they said in the article was not submerging it is better, because this will result in larger zones of keratinized tissue in the healed result. So I hope that makes some sense to you. We've covered a number of different items. I said that I wanted you to see how to preserve the soft tissue and bone around implants. If you're doing soft tissue preservation, you know you're controlling inflammation, and therefore you're protecting the bone. I wanted you to see how to manage frenum problems in both implants like Avery and teeth like Marilyn. And then, as you already know, my favorite application of soft tissue grafting is right here, that you could prevent recession in the aesthetic zone before you place your crowns, even before the temporaries. Now, Joanne was already in temps. It was planned that way. But we went ahead and did the graft after the temporary. Good. Either before the temporary or at least before the final restoration. So preventing recession. Look for those areas of thin tissue in your aesthetic restorative cases. You will be delighted with the results. And, of course, then we looked at Norma and others, how to stop recession from getting worse. Stacy with that labially placed cuspid in the very thin bone. And then all those applications could be applied to implants, but then the covering of exposed roots would just be teeth. And we saw Robin and Hillary, and we have the opportunity to cover roots for sensitivity like Noreen or aesthetics like the others. My other goal was for you to have a sense that you might be able to answer this question, to graft or not to graft, and to understand what type of graft would be useful. A gingival graft for Norma and Stacy to stop the recession and protect the thin bone, or a connective tissue graft for Meredith to help improve her aesthetic results. Well, to give you a little encouragement, I've had people come to my workshops that have had no experience doing these grafts. And Dr. Siraji, a nice young man in the Los Angeles area, came to my class the first weekend in December one year. We talked about this case, and it's very similar to Melinda, is it not? Where we could have a submarginal incision on the adjacent teeth, but a marginal incision on the tooth in question where the recession is. So we talked about it, we treatment planned it together, and this was his very first case done by the end of that same month. Here's his 6-month results and his 11-month results. Excellent results for the first effort following a hands-on workshop. So it's really rewarding for me to see these things happen. I hope that my discussion was clear, maybe more clear than this directional traffic sign, but clear nevertheless, that you can take something home and answer some of those questions about to graft or not to graft, because that is the question for today. If you're interested in workshops, the PERIO Institute does offer workshops on cadavers and on pigs. We do the pig classes for crown lengthening, soft tissue grafting, bone grafting, and the cadaver class actually for same topics, also extractions. So if you're interested, here's the PERIO Institute's website. All their contact information and their courses will be listed there. My contact information is here as well. If you're interested in an article about how to do the palatal covering for the gingival grafts, I have an electronic copy. Feel free to send me an email. I'll send you a copy. And I wish you well with all of these things, applying your knowledge, and if you want to learn more about how to do this, coming to a workshop at some point in the future. And if you do come to a workshop, please let me know that you first saw this material on the webinar. Thank you, and good luck with it.